You say broadcast.
Yep, thank you.
And me?
Yeah, and me, everybody. Yeah, thank you.
All right, I think it's 5 o'clock now, right? Welcome everybody, and it's a good evening here in Kuala Lumpur, and a good morning to our friends in the United Kingdom who's joining this webinar series. This is our second talk in this UKM Oxford webinar series on infection and immunity, and today we are going to be discussing on a very important problem actually in a country, and that's about tuberculosis. Our first talk was on COVID-19, and this time around it's on tuberculosis, and tuberculosis being an old disease, but has got many challenges actually to all of us in pediatric practice as well as in adults. We know that it's always going to be a challenge when diagnosing tuberculosis in children. And I think the advances in investigations, laboratory diagnosis has been rather slow moving for a period of time, but now there's a recent upsurge in precision medicine in terms of the diagnostic advances that I think we all should be tuned to. And that's why this reason for this topic to be picked as the second in this webinar series. Just before I introduce the speaker, I'd like to sort of describe what this webinar series is about and how it came to. And it is because of the collaboration we have in the Memorandum of Understanding with Oxford, in the exchange of students, teachers, research, as well as in expertise in trying to set up a service for infections and immunodeficiencies in our upcoming new children's hospital. So hopefully this is going to be a recurring affair when we renew the MOU with Oxford next year for probably another 5 years. And we look forward to this collaboration. It's been successful. And then I'd like to give tribute actually to the person in Oxford who has actually helped us to put this together. And that's Professor George Hollander. I think you can see him in the picture. Professor Hollander has been instrumental in making this a success for us. It's a treat actually for Oxford to actually present this webinar series for our continued professional development. So, one of the product is Dr. Adli, who is going to be the moderator for this session. Dr. Adli just completed his PhD in Oxford, and he's a pediatric immunologist in infectious and so in immunodeficiencies. And he will be, as I said, moderating the session later on. And so now, saving the last for the best is our speaker, Dr. Rin Song. And Dr. Rin Song is a clinician scientist in the Department of Pediatrics of Oxford University. And his primary research interest is in pediatric TB, with a specific interest in pediatric TB diagnostics. He is actively involved in several studies on pediatric TB diagnosis around the world, collaborating with multiple academic institutions, industry partners, as well as the Foundation for Innovative New Diagnostics, called FIND, in Switzerland. So he's really traveling around much, right, from his CV in Europe and then in US as well, because he obtained his MD and a doctorate degree in medicine from the University of Munich in Germany, and then became the Epidemic Intelligence Service Officer, sounds like a MI6 or a CIA, I think, in the TB division of the US CDC. And then he joined the faculty of the Peds at Harvard, and also the Division of Infectious Disease at Boston Children's. I think Dr. Rin Song has got a joint appointment now with Oxford as well as in the US. And he has completed his fellowship in infectious disease in Boston. So without further ado, I would like to invite Dr. Rin Song to present his lecture. Dr. Rin Song.
Thank you very much for the introduction and for giving me the opportunity to be part of this exciting webinar. And I look forward to the talk today. Just share my screen, and we will have a Q&A session at the end. Can you see the screen fine?
Yes, perfect.
Yes.
Perfect. Oh no,
It's better to be in a slideshow though. It's not in
yeah. This one, yeah?
Yeah.
Perfect.
Okay, thank you very much. So again, good evening, everyone. So I wanted to talk about the challenges of diagnosing TB in children today. And upon discussions with our colleagues, we decided to structure the talk as follows. I will briefly review some principles of pediatric TB epidemiology, and then I will present an overview on current approaches to TB diagnosis in children to give you a background there. I will review research targets and needs. And then at the end, I will briefly talk about and present some of my ongoing research work. So starting with the global epidemiology of pediatric TB, according to WHO estimates, we estimate that approximately 7.5 million children defined as younger than 15 years are infected with TB each year, and that approximately 1 million children develop TB globally per year. And this leads, unfortunately, to an estimated 233,000 pediatric TB deaths in the world per year. And it's noteworthy that a large proportion of that pediatric TB burden occurs in children under 5 years of age. So about 50% of the incident cases, and unfortunately about 80% of the pediatric TB deaths in the world occur in children under 5. And one of the main reasons for that is that children with TB are often missed in terms of diagnosis. And we call this the case detection gap. And it's estimated by the WHO, the TB reporting gap is biggest among young children. Again, you can see here in the red color that under 5, about 69% children are being missed. And in the ages of 5 to 14, about 40% of children are not diagnosed with TB. And if you compare that to all other age groups combined, this is only 35% in those populations. So why is this? What are some of the major diagnostic challenges? And this is a summary slide, and I will review that in more detail during the talk. First of all, the symptoms of TB in children are non-specific. They can be due to many other conditions and infections presenting particularly in high burden settings. Then children have also higher rates of extrapulmonary TB, which further makes the diagnosis more difficult for the clinicians. Importantly, children have also rather subtle chest X-ray findings compared to adults. And probably the most important aspect is that microbiological diagnosis is uncommon in children. First of all, this is quite difficult to obtain adequate sputum specimens from children, particularly from young children. And as you know, sputum specimens are the main specimens that are being used to diagnose adults with TB. But getting, particularly from young children, sputum is very difficult, if not impossible. Then children have what we call paucibacillary disease, meaning they have a relatively low burden with the pathogen causing disease, which makes it more difficult to confirm the diagnosis of TB by laboratory methods. And this paucibacillary disease leads to a low culture yield on respiratory specimens, particularly gastric aspirate and induced sputum, which are the recommended specimens. And culture, as a reminder, TB culture is the gold standard laboratory assay for TB diagnosis. Because of that, in high burden settings, specimen collection is rarely attempted in children. And the diagnostic accuracy using clinical criteria is unfortunately rather poor. So now I wanted to briefly review with you again the current WHO recommendations, how to approach a child in terms of TB diagnosis. So first of all, a careful history is relevant, which includes a history of a TB contact, as young children usually contract TB from a caregiver or from an adult with TB in close proximity. The history should include whether the symptoms suggestive of TB, a careful clinical examination, including growth assessment, the tuberculin skin test, which I will talk about in more detail, and again here, bacteriological confirmation whenever possible. And then investigations relevant for suspected pulmonary TB or suspected extrapulmonary TB, depending on the clinical presentation. And all children suspected of having TB should be tested or offered at least HIV testing. So what are some of the symptoms suggestive of TB? And I think most of you are familiar with that, but I wanted to review it briefly. So, you know, cough, especially a persistent and not improving cough, is one of the symptoms of TB. Weight loss or failure to gain weight, fever and or night sweats, fatigue, reduced playfulness or being less active. And these are rather non-specific symptoms, as you can appreciate. So what makes it slightly more suggestive of TB if these symptoms persist, for example, more than 2 weeks, without improvement following appropriate therapy for a specific sign or symptom. And so this could be antibiotics for cough or pneumonia. It could be in a high burden setting, anti-malarial treatment for fever, or it could be nutritional supplementation for malnutrition. So if these symptoms do not improve after these therapies, the index of suspicion for TB becomes higher. And then I mentioned already the TB contact history is really key in assessing a child for TB. The closeness of the contact is really important. The sputum smear, or if available, gene expert result of the index case, if known, is quite important. And then we know also from quite carefully done epidemiological studies, the timing of contact is also quite important. Children usually develop TB within 2 years after exposure, and most, up to 90%, actually within the first year. So that's why the TB contact history is quite relevant. If no source case is identified, you should ask whether anyone in the household has a chronic cough, and that person should then be evaluated for TB. And this is from a study done in Kenya, where the investigators evaluated the TB infection risk by smear status of the source case. And you can see here on the y-axis the proportion of children with a positive TST, and then graded by the smear status of the index case. And you can see the higher the smear status, meaning the higher the mycobacterial burden in the index case, the higher the proportion of children with TB infection. And also you can see that a female index case was much more likely to be associated with a higher positivity rate than a male index case. So what about chest X-ray for TB diagnosis? If available, it's an important tool for diagnosis of pulmonary TB. And the most common abnormality that we see, particularly in young children, is an intrathoracic asymmetrical lymphadenopathy with or without associated parenchymal infiltrate. Cavities, a prominent feature for chest X-ray diagnosis among adults, is not seen in younger children, but can be seen among adolescents. It does have limitations, however, because chest X-ray quality can often be suboptimal, and we know that there's a high degree of reader variability of chest X-ray findings. I wanted to show you here, this is one of the examples where the index for suspicion for pulmonary TB should be quite high, because you can see on the right side quite prominent mediastinal lymphadenopathy, and then with adjacent pulmonary infiltrate in the middle lobe. So this is a quite typical chest X-ray actually for pediatric TB. And then I wanted to show another example, which some of you might have seen. This is miliary TB, which you most commonly see in children with HIV or AIDS, or children on with an immunocompromised status, with really a widespread distribution of TB within the lungs. I want to talk about the role of TST and its interpretation. So the TST interpretation depends on two factors. First, it's the diameter of the induration, and then it's the person's risk of being infected with TB and the risk of progression to disease if infected. And these are the WHO guidelines. So a diameter of induration of greater or equal than 5 millimeters considered positive in HIV-infected children and in severely malnourished children. So, for example, in children with clinical evidence of marasmus or kwashiorkor. And a diameter of induration of greater or equal than 10 millimeters considered positive in all other children. And this is important, whether or not they have received BCG vaccination. There was a change that was implemented by the WHO a couple of years ago. Oops. But you might be familiar with that, and I wanted to review with that. The TST is not a perfect test. It has several limitations. First of all, you have the issue of false positive results. So this could be due to infection with non-tuberculous mycobacteria, and estimates on that vary based on TB prevalence and geographical location and the climate. Prior BCG vaccination, as mentioned. And it has been also shown that the effect on TST positivity varies based on BCG timing. BCG vaccination within the first year of life has only a minimal effect on TST after 10 years. However, BCG vaccination after the first year of life has been shown that up to 20% of individuals will have long-lasting TST positivity. But the TST can also lead to false negative results, and this can be due to technical factors, for example, due to improper storage or contamination, improper application, and also interreader variability of the induration. Biological factors are also important. Active TB disease, probably the most important one, because we have to remember that TST doesn't diagnose on its own active TB disease. It can also be the case in HIV infection, specifically if the CD4 count is less than 200, or among children on immunosuppressive therapy. And I wanted to review next also the interferon gamma release assays, or IGRAs, which some of you might have heard about, or some of you might be using. So there are two commercially available IGRAs, the QuantiFERON Plus and the T-Spot TB. And the work by measuring production of interferon gamma by T cells following stimulations with MTB antigens. And these antigens are specific for Mycobacterium tuberculosis and are absent in BCG strains in most NTMs. However, the WHO actually recommends against the standard use of IGRAs. And this is because they're quite expensive to perform. And this has been shown that they're not really adding much in terms of clinical management of patients. And important also here to mention is that comprehensive pediatric data are still relatively limited on IGRA performance in children, and that there are concerns over performance of IGRAs, particularly in children under 5 years of age, where we have found higher proportions of indeterminate results. So that's the role of IGRA in TB diagnosis in children. So next, as you mentioned, WHO has said key is to attempt bacteriological confirmation whenever possible. But how should you approach that? I'm going to focus here primarily on younger children. So the recommended specimens by WHO are induced sputum and gastric aspirate. However, as you know, both of these specimen collection procedures require usually hospitalization. You need skilled medical staff and the equipment to perform that. And due to these reasons, they're rarely used in high burden settings. And in settings where you don't have TB culture or PCR-based methods available, the specimen collection for smear microscopy alone is not considered worthwhile. And people often ask, why is gastric aspirate collection so difficult? And here's a picture from a study which I did in Kenya, where you can see where we collected a gastric aspirate, and you can see how many staff you need to do it properly, and also what an invasive and really quite uncomfortable procedure it is for a child, because you need to really put this NG tube quite deep down. It's very uncomfortable. And so it's quite difficult to obtain. And as I mentioned briefly before, smear microscopy, which we still use in many settings as the mainstay for adult diagnosis, unsuitable for children because the sensitivity is just too poor because of the post-bacillary nature of TB. So now I want to talk about the Gene Expert or Expert MTB-RIF assay. And the newer version called the Expert Ultra. So this is an automated real-time PCR platform. It detects the RPOB gene region of Mycobacterium tuberculosis, and is therefore can also detect rifampin resistance, as you know, one of the two main antibiotics for TB treatment. As such, it can be used as a surrogate for MDR TB, so it's therefore quite useful. You can get results within less than 2 hours, and it has been WHO endorsed for both adults and children, and has been implemented now in 110 countries. And I've shown a picture there. We called it initially, when it was rolled out, the espresso machine, because it's really quite easy to use. What about the performance though in children? And unfortunately, although quite convenient and much easier to do than, for example, TB culture, the sensitivity on respiratory specimens of the Expert MTB-RIF has been shown to be about 55 to 65%. And this is compared to TB culture, the gold standard for laboratory testing. And in terms of the Expert Ultra, which has been slowly rolled out over the last year or so, which is the next generation assay. And we have limited pediatric data so far, but it appears that there's about a 10% sensitivity increase compared to the Expert MTB-RIF. But so it's still, and that's important to remember, the sensitivity is still quite lower than TB culture. So this leads us to what I call the diagnostic dilemma. I like this Venn diagram here because you can see in the first circle, you can see children who are exposed with TB, then children who become infected TB in the bit darker yellow, and then you have children with true active TB in the orange, and then in the darker orange, you can see the smaller circle that you have this relatively small number of children who can be microbiologically confirmed to have TB disease. And for the clinicians, the most prominent challenge really in the field and in the hospital is that is the lower circle there. You have many children presenting with clinical symptoms which could be consistent with TB, but only a small proportion of them actually do have TB, and an even smaller proportion of those can be microbiologically confirmed. And we know from several studies that that proportion really depends on the study setting, on the assays that you use, and also on how much advanced the TB disease is in a particular child. But from many studies, we know that you can only confirm TB in about 2 to 30% of children. So that's really the big problem in terms of pediatric TB diagnosis. And I call this the diagnostic bottleneck in TB, because it doesn't only affect individual care for a child, it affects pretty much all areas of potential TB research interests that are really important actually also to address. So first of all, we have limited pediatric TB prevalence and incidence data nationally and globally for both drug-susceptible and drug-resistant TB. So the efficacy of control and prevention measures is difficult to measure. And the lack of a really true diagnostic gold standard and clinical endpoint, unfortunately, impacts various other fields of TB science. So unfortunately, very few TB drug trials are being conducted in children. We have very few pharmacokinetic studies. Most of the dosing that we use in children has just been extrapolated from adults. TB vaccine trials are very difficult to do without an endpoint. And the field has actually moved to conduct TB vaccine trials now more in adolescents and adults, partially also because of this diagnostic difficulties. And then there's quite sort of a catch-22 because validation of novel diagnostic tools which appear promising are primarily done among adults because it's so difficult to confirm TB in children. So in the next part of the talk, I wanted to present how can we try to address these challenges and what are some of the research targets that the field is looking into. So this is an expert consensus paper that was developed a few years back where we tried to develop a blueprint for an ideal diagnostic for pediatric TB. And we proposed that it should be based on an easily obtainable specimen. So ideally urine, blood, it could be exhaled air, saliva, or stool, and not based on respiratory specimens because of the challenges I outlined earlier. This diagnostic tool should be able to distinguish between latent TB and active disease, and ideally both diagnose pulmonary and extrapulmonary TB. It should meet the target product profile, sensitivity, and specificity targets for diagnostic or triage tests, which are outlined by the WHO. And ideally, they can be integrated into a point of care or close to point of care platform with rapid results. So that's kind of our dream where we are trying to aim for. And going back to this Venn diagram, I wanted to show you visually how some of these research targets could be addressed. If we're looking at children with microbiologically confirmed disease, one goal is to identify a more feasible combination of specimen types. For example, stool, urine, or nasopharyngeal aspirates, which are just much more easier to collect than gastric aspirates or induced sputum. A different research target, and this is kind of the holy grail of our field, would be to identify novel diagnostic tests to increase the proportion of children with laboratory confirmed TB compared to the relatively low yield of culture and gene expert that we currently have. And the third one, which is gaining more interest over the last few years or so, I would say, is to identify novel screening approaches to rule out TB. Because as you can see here, and as I mentioned earlier, you have many children presenting with symptoms that could be due to TB. But if you have a well-performing screening test, you can try to rule out TB in many of these children, so that could really facilitate the clinical management of these children. So and how would such a screening test for TB work? And I decided to mention that because I think that's an area where we are making progress, and also in the adult field. And I'm quite hopeful that over the next couple of years, we might have some important advancements in that particular area. So how does such a triage work? So you have children presenting with symptoms suggestive of TB, and then you perform this screening test. And if it's negative, you have ruled out with a pretty high negative predictive value TB. And if it's positive, then you obtain further testing for TB. So such a triage test should have a high sensitivity so that you don't miss children with TB. But importantly, you accept a lower specificity of such a tool. So the development of such a tool is quite different compared to a diagnostic test where you also need very high specificity. And this is a slide which I've developed actually a few years back as kind of a concept how in the future and we might be able to develop algorithms for pediatric TB diagnosis. And so you start on the top left corner of the child suspected of having TB. Then you perform ideally non-invasive or point of care screening test, or could be tests. If they're negative, you can just observe the child. If they're positive, you perform further workup. Ideally, you'll have non-invasive diagnostic tests. And if they're negative, then you might consider the more standard repertoire for TB diagnostics, chest X-ray, TST, TB contact history. And if those non-invasive diagnostic tests are positive, only then you would, if needed, move forward to specimen collection. And this could be, for example, if you work in settings with high drug-resistant TB prevalence. And then, oops, sorry, just wanted to look at the time. And then I wanted to give you some research updates on, I selected 2 of my current ongoing studies just to give you some updates on the field and on some new approaches for pediatric TB diagnosis. And these are 2 studies. One is called the Total TB study in Kenya, and the second one is called the Rapid TB study. So the Total TB study's objectives were using expert MTBRIF and TB culture among children younger than 5 years of age. And we focused on children of that age group because, as I outlined earlier, these are really the most difficult to diagnose children. We wanted to identify the best possible combination of specimen types and diagnostic tests for TB diagnosis, and also determine a feasible and sensitive combination of specimen types and tests. The design was a prospective cohort study of children under 5 years of age. We enrolled HIV-infected, HIV-uninfected, and HIV-exposed children, all with a high clinical suspicion for TB. Our enrollment criteria were prolonged symptomatology despite treatment. And this is based on what I mentioned earlier, that this increases your suspicion for TB if children still present with symptoms after appropriate treatment. So these were therefore cough greater or equal than 4 weeks, malnutrition greater or equal than 3 weeks, cervical lymphadenopathy greater or equal than 4 weeks, or fever greater or equal than 1 week. And also we decided to only enroll children who already had parenchymal abnormalities on chest X-ray. So we had quite rigorous inclusion criteria. This study was performed in Kisumu in Western Kenya and was a collaboration between the US CDC, the Kenya Medical Research Institute, and I started the study when I was still at Harvard and now at Oxford. The study procedures were as follows. We admitted the children for physical examination and specimen collection. We obtained a digital X-ray with blinded reading. We performed a TST and the quantiferin gold intube, so one of the IGRAs. We tested all children for HIV, malaria, and helminths. And then we had in-person follow-up evaluations at 2 weeks, 2 months, and 6 months after enrollment. TB treatment or isoniazid preventive therapy were provided according to study clinicians and national guidelines. And then finally, we classified all children into confirmed TB, unconfirmed TB, or unlikely TB according to international standard definitions. And here's what the specimen collection overview. So from each enrolled child, we collected the following specimens to be really able to compare the diagnostic yield of the different specimen types compared to each other. 2 nasopharyngeal aspirates, 2 induced sputum, 2 gastric aspirates, 2 string tests, 2 stool specimens, 2 urine specimens, 1 lymph node fine needle aspirate, and 1 blood specimen. And we tested all these specimens by TB culture and by expert MTP-RIF. And blood was only tested with culture because the expert is not very sensitive using blood. And these are the cohort characteristics. We enrolled 300 children into the study. The median age was 25 months, 50% were female, 26% were HIV infected, 22% had evidence of severe malnutrition as defined by a weight for age Z-score of less than -3. 9% had moderate malnutrition and 13% had mild malnutrition. 97% were BCG vaccinated, 15% had a positive TST, and 32% had evidence of a household TB exposure. So this was cut off at the top. And this is the diagnostic yield of the specimen types in the end. So we had in total of the 300 children, we had 32 children who ended up having confirmed TB by positive expert or by positive TB culture. And here's the performance of the different specimens. And you can see here the performance by smear microscopy, which was very poor, and therefore outlining again the point that smear microscopy is really not useful in young children. And in terms of the different yield on the different specimens, you can see that gastric aspirate and nasopharyngeal aspirate identified the highest number of children with confirmed TB, 22 out of the 32, followed by induced sputum, 15, string test, 13, stool, 14, lymph node aspirate 3, and then urine only 4, and blood only 1. And I briefly wanted to talk about the string test. This is something we developed with a collaborator from Colombia and from the US. This is a nylon string which is attached to the NG tube used for gastric aspiration. You can see that on the left picture, and is then left in place for 2 to 4 hours. And you get a distal esophageal specimen. So because you get a gastric aspirate, you get at the same time also the string test. So it's, in a sense, it's a 2-for-1 procedure that we evaluated in this study. And here I wanted to show you the diagnostic yield of different combinations of specimen types. So first, if we look at the reference standard, and here, as I mentioned earlier, this is induced sputum or gastric aspirate, as recommended by WHO. 2 induced sputum diagnosed 20 children of the 32, 1 gastric aspirate and 1 induced sputum, 24, 2 gastric aspirates, also 24. But then, for us, intriguingly, what we called minimally invasive specimens were able to identify an equal number of children with confirmed TB compared to the much more invasive respiratory specimens as outlined in the reference standard. So 1 nasopharyngeal aspirate diagnosed 22 children, 2 nasopharyngeal aspirates 24, and 1 nasopharyngeal aspirate and 1 stool 25. And finally, we looked at different combinations which would include more invasive specimens, and so you can increase that number by using these combinations. If you do 1 nasopharyngeal aspirate plus 1 gastric aspirate, we were able to diagnose 27 children, 2 nasopharyngeal aspirates and 2 gastric aspirates, 29, and 1 nasopharyngeal aspirates and 2 gastric aspirates and 1 stool, 30. So you can nearly diagnose all of the children with that combination. So the conclusions of this study were that the combination of minimal invasive specimens, nasopharyngeal aspirate and stool, had the same diagnostic yield as the invasive gold standard specimens, induced sputum or gastric aspirates. And the utility for that is really in routine programmatic settings, particularly in high burden countries where collection of these invasive specimens is just not feasible. And we also found that bacteriological diagnosis may be improved by using a combination of invasive and non-invasive specimens. And the utility for that is if there's a concern for drug resistance, it would be useful in clinical trials, or if you have obviously the capacity to do that, then you can increase the sensitivity by using such a combination. But then also important to highlight, despite this very extensive sampling and testing, and this has been the most extensive pediatric TB diagnostic study done so far in terms of different specimen types and assays, we were still a large proportion of TB disease was still not bacteriologically confirmed. And that goes back to this Venn diagram that I showed you earlier, where you can only really diagnose such a small proportion of children with confirmed TB. And in our study, despite this really invasive and quite extensive workup. And then to conclude, I wanted to briefly present you the RAPID TB study. This is a study led by my DPhil student and Dr. Laura Ulbrich. And here in this study, she's evaluating several new tests for microbiological confirmation. She's looking at the GeneXpert Ultra. As I mentioned before, pediatric data is still quite limited on the Expert Ultra. And she's looking at antigen-based detection. This is based on the antigen called lipoarabinomannan, or LAM. It's a cell wall component of Mycobacterium tuberculosis. And there are some emerging assays using urine, where you can detect LAM in the urine of adults and children with TB. And then as an outlook for the field, and where a lot of work will be done over the next couple of years, is to look at host immune responses as new approaches to improve TB diagnosis in children. And she's looking at cellular immune response assays. There's a T-cell activation marker for TB, which has been developed. It's called the TAM-TB assay. And then as part of the study, we're also looking at host biomarker validations. We're looking at a serum-based host protein biosignature. So using proteomics, looking at different cytokines in blood. And then we are also looking at host RNA gene expression profiles, where there have been some advances made over the last few years, but not yet applicable to be implemented in any kind of field or clinical setting. And this is a large consortium here, and I just wanted to highlight the different enrollment sites. The study is being done in Tanzania, Mozambique, Malawi, South Africa, and India. And there are a number of academic and industry partners listed there. And in terms of the methods of rapid TB, this is a prospective multi-site cohort study. The population here is children younger than 14 years, so it includes the less than 5 years, but also older children, all suspected of having active TB. The sample size target is 1,000 children, and Dr. Ulbrich has made really excellent progress with that study, and has enrolled so far more than 600 children. And importantly, has had so far a really high number of children with confirmed TB, 25% actually. So this is really quite remarkable and will be very useful for the evaluation of these novel markers. The enrollment time might potentially be a bit need to be prolonged because of the COVID pandemic, but we are planning for it to be concluded by December 2021. So results of this study should be hopefully out relatively soon, and hopefully I will have the opportunity to present to you some of these results and some of these new emerging assays that I briefly mentioned. And this is the end of my talk. I would like to acknowledge various academic collaborators around the world and industry partners from all the different studies. The funding for these efforts come from the CDC, the USAID, the US NIH, the University of Oxford, NIHR, the German funding organization, BMBF, FIND, and EDCTP, so various funding partners. And I thank you for your attention, and I look forward to the Q&A session now.
Okay, thank you so much, Dr. Ring. It's a very excellent talk. It's a very nice summary overview of, yes, definitely the challenges that I think all of us is having on diagnosing TB and managing TB in children in particular. And I think it's very interesting to see the two study that you are involved, and I think that's a very nice sharing session. So for the Q&A session, if anybody from the audience have any questions, so you can basically post it in the chat for a Q&A. So I could basically post it to Dr. Rin. But before we do that, if there is any comment or feedback or any question from Professor George Hollander or Professor Chia to Dr. Rin to start the ball rolling.
Well, yeah, thank you very much, Rin. Very inspiring overview. Obviously, as an immunologist, I was wondering, is there anything known how quickly the TST response changes to a normal response once the child has been calorically supported to the point that malnourishment is not an issue anymore? So what of this is hardwired in the immune response, and what of it is basically an overall issue of malnutrition?
Thank you, George. That's an excellent question, which hasn't been properly addressed yet, I would say, in the field, because in routine practice, repeating TSTs is usually not recommended for concerns for boosting. And I'm actually, I would have to look into that, whether this has been done in research trials. I'm actually not familiar with it. It's a very, very good
It was just a general question because actually when I worked at the Children's Hospital in Boston, we would see individuals who had come through various refugee camps and were finally, could finally call the Boston area as their home. And indeed, repetitive TST had changed from a negative to a positive response. And one of the issues there was, is it repetitive boosting? And what you get is, a really just a good prime boost immune response, or was it the fact that over time individuals were less calorically stressed? So that was the basis to my question.
Thank you. I will look into that. I'm not aware of any prominent literature on that where it's been done in rigorous research or even observational studies settings. I will look into that. It's a very good question. Yeah, thanks.
Okay, we have one question from the audience, and this is actually a common question. I think you highlighted this partly in your talk, but the question is, how do we diagnose smear negative pulmonary TB in children, knowing that the smear microbiome, the smear is very the result is very poor in children. So how do you do that? How you go about in diagnosing PTB in the smear negative children?
Yeah, thank you for the question. So I assume this would apply to a setting where you don't have anything else than smear microscopy available. So no gene expert, no TB culture, only smear. So unfortunately, this is the case for a large area of the world. And in these cases, if you have negative smear microscopy, if you can get a chest X-ray that can help in the diagnosis, as I had outlined, but then it becomes a constellation. It's a composite clinical diagnosis. Then you have to evaluate a TB contact history, which is quite crucial. So if there's been a recent TB contact with close proximity, and then it's a combination of the presenting clinical signs and symptoms, physical examination, if you have TST, but if you have only smear, you don't have a TST. So then it becomes primarily a clinical diagnosis and to a certain level clinical judgment. And that's really this diagnostic dilemma, which I've shown in the Venn diagram, because you end up over-diagnosing TB, but also you're obviously under-diagnosing TB. And it is quite, you have to rely on these clinical and epidemiological data, but the accuracy of that is unfortunately quite poor. But you can only, if you have only that available, you have to use what you have. And if you're dealing with a child younger than 5, I usually say that you err on the side of over treating, because TB in children under 5 can progress quite rapidly after infection to disease, um, and TB treatment is usually quite well tolerated. So if there are any doubts, I would rather over-treat than under-treat.
Yeah. So there's another question. This is about the tuberculin skin test. And the question is that, would you recommend doing TST in young infant less than 1 year old as part of the TB workout, since it is difficult to interpret?
It depends, I think, on what other tools you have available. If you're doing, for example, if this is being done as part of a contact investigation and you're trying to identify children who you want to place on isoniazid preventive therapy, this could be quite useful. And in children under 1, if it's positive, it is quite helpful. If it's negative, you have to take it with a grain of salt, of caution, I would say. But if you can do it, it is helpful.
I think possibly an add-on question on the smear-negative PTB. I think historically, people actually do some additional blood investigations. People were using ESR, but I think a lot of people have things that it is not specific. It's not a very good marker. What's your opinion about it? As part of the extension of the smear-negative, will any additional available blood markers or blood investigations or other investigation you would do to possibly support treating these patients?
Yeah, and thank you for the question. Blood markers, so meaning here full blood count or inflammatory markers like CRP or ESR, are not that particularly helpful, I would say, in delineating your decision-making process for a particular child, because we know from several studies that inflammatory markers are usually elevated in children with TB, and they might have some increased white blood cell count, but these findings are so non-specific, and in these children eventually you have to consider a broader range of potential infectious disease etiologies, and in most of them you would actually see these findings. So I would say in the sense of an initial workup of a child who presents to you with fevers and you're concerned about infectious process and the CRP and the white blood count would be useful, and you do that as part of your routine clinical assessment, then I would, of course, do that. But I wouldn't. We don't have the data to suggest that you can use it to make a more defined approach for using those for TB diagnosis in children. And we're looking at in our studies. I think for time purposes, I didn't mention 2 other studies that we're currently setting up in multi-site also. But we're actually looking at CRP, but more as a combination triage test. So we're looking whether you can use CRP in addition to some other host biomarkers as a screening test to rule out TB. But currently in clinical practice or used alone, it can't really help you much.
Okay, so there are related question on IGRA. The question is, have IGRA usage being validated in children under 5 years old? And I think possibly you can answer this. Does IGRA is an alternative to tuberculin skin test?
Yes, that's also a very good question, and a question where there even there are conferences about that, actually. This is such a big area. So IGRAs have been evaluated in children under 5, but as I mentioned earlier, the data is still relatively limited in this age group, and so we don't have a clear, how can I say it, thinking at the moment how to really interpret those IGRA results in children under 5. If they're positive, they are helpful, but as I mentioned, you encounter, particularly in children under 5, a high proportion of children with indeterminate results. So you don't really know how to interpret the test, and the negative IGRA, particularly in children under 5, is still a bit skeptical to what level that can be trusted. And so that's why WHO has actually stood up and recommended not to use IGRA in addition to the TST, or in lieu of the TST. So I think the field is still a bit, it's a bit unclear at the moment. And to be honest with you, I think some of these questions might never 100% be answered, because the field is trying to move away from IGRAs because it requires a blood draw. It's very expensive, and based on the data we have so far, there doesn't seem to be a considerable gain in diagnostic accuracy over the TST.
I think, if I'm not mistaken, this is a question from a senior consultant pediatric infectious disease here in Malaysia.
Adli, can I chip in here too? Because I've seen Kamaro posted the question, and it's
yes, question true.
The question that I would like to pose to Rin.
Yep.
The two things here, yes, it's spot on. Actually, we think alike. I think here is that the TB-CNS and as a gold, well, the TB-CNS is a gold standard, and we know that it takes a long time, Rin. So with the MJIT, which can expedite it to about 2 weeks, and you mentioned about the gene expert, which is up to 2 hours, as early as 2 hours. So is that your approach now in terms of the diagnosis, sending these samples for a quick so-called know the situation immediately, and then take it from there in terms of tapering down the treatment if the culture comes back later on and it's negative? Because you did say that the sensitivity of the gene expert is pretty low. So what's your thought on this, number one? Number two is, I really like your study in terms of the tests, the non-invasiveness, and I think I want to applaud you for thinking about stool. I mean, you know, we keep taking out things from the stomach. I know that eventually it's passed out, and stool is quite easy to obtain, and not having to fight with the child in putting in a Rouse tube or an NG tube to get the sample. So really, I think we should have thought about stool early on, and to see our results is pretty impressive, you know, with the 3 tests, the NG plus the, the nasopharyngeal plus the gastric and plus the stools gives almost a perfect yield. So maybe we should rewrite our protocol in obtaining these samples actually for tests. So yeah, these are the 2 questions. Can you share your thoughts on this?
Yeah, thank you very much for these questions. So in terms of the first question, midget culture, so the liquid, so for the audience, that's the liquid TB culture, which provides a bit more rapid growth of mycobacteria as compared to the solid TB culture. It is still the gold standard. So in settings where it is still the most sensitive laboratory tool that we have. So in settings where you can send it, we usually would still recommend that you do, but this is really limited by the availability of such of midget cultures. And although I didn't want to, I mean, the sensitivity of the expert and expert ultra are lower than TB culture, but we have to remember that it's still much higher than smear microscopy. So in settings where you don't have TB cultures available, but you do have GeneXpert or now GeneXpert Ultra available, you gain substantially actually over smear microscopy, and you get the results back much earlier. So that's why even though the sensitivity is lower than TB culture, you get the results back earlier, and you can confirm TB in a much higher proportion of children than smear microscopy alone. So so that would be my answer to that question. In terms of
sorry, can I just interject there? Do you then recommend a combination of this test, GeneXpert first, and then at the same time send for TB culture, MGIT?
if you have both available, that would be ideal to send both, because TB culture, even if the expert would give you a quick result, and also you would know about rifampin resistance, and then if it's negative, the culture might still become positive a few weeks later on. So that's why if you have both available, I would send both, but it might only be available in hospital settings in certain
and if both negative, then we can stop treatment pretty quickly, right? Rather than having to wait for the 6 weeks.
No, actually, so that's because if you recall from that Venn diagram, only this was this big, no, not this big, this dark orange circle. Only 2 to 30% of children who we do think have TB have laboratory confirmed TB. So the majority of children who really, based on clinical presentation and other parameters, we do really think they have TB, have a negative culture and negative expert. So if your clinical suspicion is high, you should just treat. And kind of one of the main dogmas of pediatric TB treatment is once you start a TB treatment, you should just complete it regardless of the investigations that you get back, because the sensitivity of both the expert and the TB culture are not high enough that you can say if they're negative, the child doesn't have TB. So you commit to TB treatment once initiated. That's also what WHO recommends. That's really the issue, that none of these assays, if TB culture would be 90% sensitive, then you could argue, yes, if it's negative, then it's very unlikely to be TB and you could stop. But because in children, none of these assays have even close sensitivity that is high enough, so you're committed to TB treatment once started.
Well, thank you for the very important point that you made. Yeah, thanks.
And just going back to the stool comment, thank you for the comment. It has gained a lot of traction to test stool for TB in young children, because we thought about it. We're collecting gastric aspirates, which is already a specimen which is entering the gastrointestinal tract, and so we thought, well, maybe we can find TB then in the stool, and so that turned out to be the case. And what is a bit more complicating the issue is that the processing of stool is a bit complex, I would say. It's a complex matrix, and particularly to use stool with TB culture is quite complicated, because you need to decontaminate it quite aggressively, because otherwise you have overgrowth of all sorts of different bacteria over the mycobacteria, which grow very slowly. But using stool with PCR-based methods has shown more promise, because there you don't have to worry too much about cross-contamination with other bacterial pathogens. And so actually we, with the Foundation for Innovative New Diagnostics, I started development, we call it a stool processing kit. I didn't show it because of time purposes, but where we collaborated with a design company to come up with a very easy process how to use stool with GeneXpert, and we developed this bottle where all the buffers and filters are integrated into this bottle, and you can just scoop stool into the bottle, and then you shake it a few times, and then you can just squeeze it into the GeneXpert cartridge. So I've done a lot of work on that, and it's now part of the rapid TB study that my DPhil student is conducting. So there will be more data coming. And people often ask me, can we now just test, start testing stool? I mean, you could, but you would need to discuss with the lab carefully the SOPs for that, and particularly for TB cultures, it is quite difficult. But for GeneXpert, it's definitely possible.
Yeah, I think that's interesting.
Sorry, just quickly, the nasopharyngeal aspirate, is it a normal catheter that you use, or is it a special one? Because I'm interested to, to see whether we can actually do that too.
Yeah, thank you. It was just a normal catheter, so a nasopharyngeal aspirate that we use, for example, for influenza testing or for other specimens. So it was a standard collection methodology for the nasopharyngeal aspirate.
Thank you.
Yeah, I think it's interesting. Possibly the stool culture for TB is something we are looking forward, and I think a bit of update from Dr. Kamaru actually shared with us saying that they did diagnose a patient with a stool, a patient with abdominal TB as it was positive from the stool TB culture. So I think that's in line with what Dr. Spring is saying. So moving from stool culture as part of it, I think there are two questions. And this one is from KB, and it says that there are some scoring system used and published for diagnosing TB in children. So what is your comment on that? I think this is actually an example, so I think from maybe a study in Brazil. Are you aware of it?
Yes, so these scoring systems, I mean, our thoughts in the field are that they're relatively poorly validated, but this is not a fault of the investigators. It's a dilemma because you don't have a gold standard, so it's very difficult to validate these scoring systems if you can't confirm the disease that you're looking for. So the WHO currently does not recommend to use these scoring systems. And there have been various developed, but none of them have been properly validated.
Okay, I think this another question possibly referring to your study in Kenya, I guess. And in your opinion, would the non-invasive specimen study results being different in countries with low prevalence of TB compared to the high prevalence that they've seen in Kenya? So what's your input on that?
Yeah, that's a very good question. And this is definitely something worthwhile to consider. And the answer is we don't know that. In our study findings with the really quite impressive field of the nasopharyngeal aspirate and stool have been picked up by our research community, and other studies are now currently being performed looking at this combination of these two specimen types, and also slightly lower burden settings. But honestly, this has not been replicated yet in, for example, a very low burden setting. So that we don't know yet. And we also have to keep in mind that these children in Kenya, they were actually quite ill. I mean, we selected children who had a very high clinical suspicion for TB. They had abnormal chest X-rays. So we need to carefully evaluate how these findings can be replicated in children who might have less advanced disease, and also in settings with lower TB prevalence. So that's a very good point. Yeah.
Okay, I think now it says 6:08, and we possibly we thank you so much to Dr. Rin for a very good talk, excellent talks, and I think a very fruitful discussion. Maybe anything before we go on, any last feedback or input from Professor Chia or Professor George Hollander?
So I have nothing to add. I thought this was a very instructive and very excellent overview of the diagnostic possibilities, and something that has clearly marked my training in pediatrics and my work as a pediatrician as a repetitively highly challenging issue, namely, what is TB really presenting itself as, and how can we capture it best? So thank you very much, Ring.
Thank you, Josh.
For me, if Adli, if I may ask Dr. Rin maybe one more question, I think we can afford that, right? It's some time to about 6:15 here. It's that you know, IGRA, you have mentioned it very nicely, that it seems to have rather poor results for children less than 5, and I'm aware that you are doing some studies on T cell activation and you know, and markers in that manner. So, is there anything in the immune response that you think should be candidate without spilling too much of the beans from what you're doing in terms of choice marker for you know, for diagnosis of TB? I mean, since IGRA is quite unreliable when you're very young, so is there anything in the immune response that you think should be looked at?
Yeah, so I think the field is moving beyond interferon gamma as a single immunological marker, and that's where some of the advances in, for example, in host transcriptomics have been interesting. So I personally think that host transcriptomics is a big field, and because of time purposes, I didn't dive into much detail at all in the talk, but there's some promising data from adults, and also that you can, from some studies where they've used host transcriptomics to identify adults first, and then also a study from adolescents who had higher risk of progression to TB disease. So using the host transcriptome, you can try to identify those and potentially initiate TB treatment before they actually develop TB disease. So I think the host transcriptomic field is one to keep an eye on. The pediatric data so far, I would say, hasn't been able to come up with distinct signatures that are performing as well as shown in some adult studies. And I think my personal view is that host transcriptomics might be useful potentially as a triage tool, as I mentioned before in the talk, where you can use such a test to rule out TB. So you have a high sensitivity, but you accept a lower specificity. I think we might be able to make advances towards that. And this is a much more granular and more refined look at the immune response to Mycobacterium tuberculosis than just the interferon gamma release assay. And also, I didn't mention that also because of time purposes, but the company that's producing the Gene Expert is called Cepheid, and they're now they have developed a what they call a host response cartridge, where you can use the same machine that you use for Gene Expert, and you can use this host response cartridge, which is based on a 3-gene signature, which has shown some promise in adults, and so you can just draw blood and put it into this host response cartridge. And there's some ongoing studies in adults, and also we're doing a study in children on that. So I think I wouldn't expect, to be honest with you, that's my very personal view, but not too much more significant advances in terms of IGRAs. But the TAM, the T cell activation marker, shows some promise, and the transcriptomic field is quite interesting.
I think that's perfect wrap up, if I may, Adli, before closing, to say that Dr. Rin Song actually gave a very very nice final words. And for those of us who are not into research, transcriptomics is all about things like bioinformatics, that you can have a chip and you can see these transcription factors in the signaling, in the inflammation pathways and related with the disease process. So I think precision medicine have set foot here, and we're going to see more of it soon, right, Rin, in terms of diagnosis of infectious disease and for other diseases for the matter. So I think it's time to wrap up now, if I may, Adli. We will close the session, right? Thank you so much for all who have attended and participated. Thank you so much to Dr. Rin Song, who has actually presented so elegantly an update on TB diagnosis. And thank you also to Professor Hollander for being with us, and to see that this event is really being successfully carried out. And for those who really like this session, we just want to whet your appetite that there'll be another one in the series, and it'll be in January next year, and it'll be on pneumococcal disease. And it's very likely so that we have that because we are starting our pneumococcal vaccination, I think this month itself, or latest by next month in the new year. So it will be very timely to discuss this topic. And also, for those who want the CPD points after this, there will be a QR code for you to scan. Otherwise, I think that's about it. Again, thank you all for participating. Thank you for the questions, and thank the speakers and everyone who's involved in this event. And it's me here, Professor Chia, signing off, and have a good evening. Thank you.
Thank you again from my side. It was a great pleasure to talk. Thank you again.
Thank you. Bye-bye.
Bye.